There's only 3 people on. One of them's Ben. Only 3 of them are left. And Ben is one of them.
So you said you're junior and next December 5th.
It started at 9:05.
Because I assume you won't fly. It's,
Yeah, I don't know. This is 20 minutes.
right.
Oh my god, I need eyeglasses to see all that.
We'll make it bigger, don't worry. How about now?
That's better. I know you're old.
Yeah, exactly.
It's coming for all of us. So, do we not see that there's nobody on the Zoom?
So, should I start admitting them?
Oh,
Right?
good, yes.
Alright, okay.
I mean, don't you think, because
Sure.
they're gonna wonder what's,
Yeah.
that they're in the right place or whatever, because we did say 8:45 we'd start letting them in.
Okay.
Sorry. Hello.
Hi, Sterling.
Oh, you work with Larry.
Larry?
Sterling?
Yes.
You work with Larry?
Larry,
Ross.
yes,
Yeah,
indeed.
yeah, I'm Jenny.
Yes, yes, indeed.
Nice to
yes.
meet you.
I think you were at the presentations first.
Yes, I was.
Yes, I met
Oh,
yeah,
you-
that's what.
You want me to?
No.
Oh,
Okay,
no
actually, I
worries.
haven't read it. I haven't read it.
Yeah.
People online can't hear.
Oh, thank you. It means a lot. Yeah, yes. So just make yourself comfortable.
They're all muted.
Yes, of course. Pardon?
Sterling.
I'm Carla.
Hi, nice to meet you.
Oh, are you Carla Philip?
Yes, I am.
Oh, hi, I'm Jenny.
Hi, nice to meet you.
Welcome.
Thank you so
They
much.
all should have done.
Where do I work?
Yeah.
I'm with
An
Vancouver
option
General
where they
Hospital.
only
I'm
referred
one
us
of the
and so on,
regional
but they
leads
were
in
not
acute care assistant.
Like a webinar type.
Thank you for coming.
Yes.
Good morning.
How are you?
Good, thank you. Sean Palmer, how are you?
Good morning.
Sorry.
We work together.
Oh.
Very well.
That was good, thank you.
Yeah.
Should we send you the back of the,
Is that what the cool kids or something? Not at all, sir.
Tell me what the sound now is.
Let's put in a chat. We're going to start in a few minutes.
I haven't done the fishing for the pump for it.
No.
It's just a conversation.
I do not know. So I suppose
So I think that's what you wrote.
I am the regional chief of long-term care. Yeah, I know what you're saying.
Yeah, so I can, come from SPOR, I won't be seeing you.
Okay.
So,
Should I start
so,
the-
do you know?
Should
Yes.
I start the recording?
Yes.
Okay, so I was working.
We did talk about therapy.
Yes, okay, yeah.
Just start like when I'm about to start to say.
Okay.
So through that, I was trying to get some support to, I can say that sort of way.
Right.
Yeah, that was.
Yeah, we work quite closely with her.
Good.
Yeah.
Yeah, she's great.
Yes, and I think she's planning on coming to Toast. That's how I knew about it.
She might be online, I guess.
Yeah.
Okay.
I think she was pretty first meeting when
Okay.
things changed.
Yeah.
Mrs. Griswold.
Yes, hi.
Nice to meet you.
Yeah, nice to see you.
Yes, I'm.
Your friend Craig's, your Craig's.
Yes, I'm.
Nice to meet you. I'm Jenny. Oh, we're gonna be presenting on this computer.
Let's give it one more minute, folks. People are coming on.
No, I was gonna say.
You okay?
Sweet time, please. Nice to meet you. I'm good. Oh, no, don't worry. I know, it was been horrible. So it's all good, we're all settled, and we're gonna do great. Hi.
So I'm doing like on the health research business side, like trying to sort of advocate for that sort of approach.
And the gauntlet approach.
Conditioning teams like across the province, they recommend so hopefully like whatever happens with these needs, she is there.
All right, I think we'll get started. Good morning, everyone. Thank you for being here, both in person at VGH as well as online. Fantastic to see so many people joining.
Recording in progress.
So many people joining online and here in the room. My name is Craig Mitten. I'm a professor in the School of Population and Public Health at UBC and a scientist in the Center for Clinical Epidemiology and Evaluation at VCHRI. And I'm really pleased to host this session today. I'll be your facilitator, moderator. We've got an exciting lineup. We are just thrilled to bits to be able to share this work with you that we've been engaged with over the last 12 months. And we also want to make this session as interactive as possible, both for those of you online and those in the room, acknowledging that with a hybrid event, it is always challenging to get excellent engagement from those online, but we will do our best as we go. Before any of that, though, I'd just like to acknowledge that we are on the traditional and unceded territory of the Squamish, Musqueam, and Tsleil-Waututh. It's a real privilege to be here on this territory, and it's just amazing that we can live and play and hang out in such a beautiful spot with the sunshine out, the mountains, the water, and I'm very grateful that we can gather here today. So the objectives for today are twofold. One, to share findings from our research project, which was exploring the cost of long-term care in institutional versus home-based settings. And secondly, to discuss implications out of this work for policy and practice in BC. The format that we're going to take is to have two presentations, and then we're going to have a short coffee break, and then a fair bit of time for group discussion to really stimulate discussion and bring out what we have in mind from drawing the links from the research findings to the policy side. Before that, though, I just have a little bit of housekeeping. First off, I did want to introduce our research team who has been so diligent in this work. First of all, we have Jenny Arnston, who is, one could say, a patient partner in this work, but I would say, as a researcher, we have research team members and patient partners. I would say she was a team member, and I don't love the distinction of patient partners in this context. When Jenny was at the table throughout this whole project, she actually even literally conceptualized the research question, and so to give you full acknowledgement, Jenny, for your participation and your guiding us, your enthusiasm. Jenny will share about her journey in the second presentation, so I won't cede any of that now, but just to say thank you, Jenny, for your presence and your enthusiasm throughout this whole day and this whole project. And then we also have a number of my team from C2E2 who has been instrumental in getting us to this point. So you're going to hear from Smita and Nora, who are two researchers within C2E2, and they're going to carry the first presentation. And then as well, we have Neil Smith and Gavin Wong, who have put in a lot of work over this last year in getting us to this place. You also, if you're in the room, you'll see there's a few cameras on the go, and that's largely for KT purposes after this event. So just try and ignore the mics and the cameras. They're operating in the background as much as possible. And in that, just be assured that we'll be very thoughtful in any KT that goes out with respect to individuals and their comments. So we're going to try and focus any of the KT from the presenters, but we would like to have the information in the background with helping us to summarize and put out any statements that arise from today. And then in addition, if you're online, you'll note that we've already started recording on that. But once we do get to some breakout rooms later in the day, you will be assured that anything you say in the breakout rooms will be held within that, except for what's reported out broadly to the group. One thing for those online, and Amarildo from our center is managing the online activity for us. We're just going to ask that online people simply share their comments and questions through the chat as opposed to going off mute, just with this hybrid format and wanting to give everyone an opportunity to share, just to have you put in your comments and questions in the chat, and then Amarildo will either speak to those or pass those to me, and I'll share them with the whole group. Anything else to note before we get going, folks? Nope. Very good. Good. Fantastic. Okay, then without further ado, I'm going to turn it over to Nora and Smita for our first presentation.
Well, we were going to do that introductory activity for the people that are online and the people that are here.
You're right, Jenny. Thank you. Yes, appreciate that. Nora and Smita, hold for a moment. You see there's some cards in front of you and some pens, and if you're online, just in the chat. We just wanted you to write down what brought you here today. So it's just trying to get at what your interest is in this topic, where you're coming from in the system, and you don't have to, obviously if you're online, your name will be associated as soon as you write in the chat, but for those in the room, you don't have to write your name down, just what brought you here today, and can do that for the cards in the room as well as the chat to write that in so that we can have a bit of information as to how and why we are gathering. And as you do that, I'm going to turn it over to Nora and Smita to get us going on the first presentation.
Thank you. Okay, so my name is Nora Fripp. I am a research scientist at C2E2, or the Center for Clinical Epidemiology and Evaluation within VCHRI, and I'm going to be presenting alongside Smita Roy, who is a MSc student at the School of Population and Public Health. And our presentation today is going to be on evidence-based cost accounting for long-term care beds in home-based and institutional settings. And we're going to be presenting the results from a scoping review we conducted on this project. So we wanted to begin again with a land acknowledgement to acknowledge that the land on which we're gathered today, which is the land that many of us are fortunate enough to live and work on, is the traditional, ancestral, and unceded territories of the Coast Salish people, including that of the Musqueam, Squamish, and Tsleil-Waututh nations. So to jump into the background, I'm just going to start by defining long-term care as we're going to discuss it today. So long-term care, or LTC more broadly, refers to a range of services and supports that is provided to individuals who have difficulty managing activities of daily living due to chronic illness, disability, or aging. So within this broader definition of long-term care, we have institutional and home-based long-term care. The institutional long-term care is sort of that typical long-term care setting that we envision, and this involves care provided 24/7 in dedicated facilities such as nursing homes, and it includes medical care as well as personal support care. And then home-based long-term care refers to care that is provided within an individual's own residence, and it combines usually professional medical services as well as informal care from family members and potentially others as well. To provide a little bit of context about institutional long-term care in Canada, so long-term care is generally funded from both public and private sources. As is the case with other sectors of healthcare, long-term care is administered provincially and territorially, and public subsidies do exist for long-term care, and these subsidies are usually income-based, so more available for low-income individuals. These subsidies can apply, of course, to publicly financed facilities, but also in some private facilities, depending on the province. And access to facilities is application-based and considers factors such as citizenship, residency, age, and health status, among others. So to zoom in and provide a few stats about institutional LTC in BC, and these are some stats according to a 2023 report published by the Office of the Seniors Advocates of BC. So according to this report, the average age for the 22-23 year of individuals in institutional long-term care in BC was 83 years old. The wait time to access long-term care on average across the province is 101 days. This does vary across regions, with the lowest wait time being in the Vancouver coastal region at 65 days, and the highest being in the Northern Health region at 278 days. And for folks in institutional long-term care, the average length of stay is 827 days, or 2.3 years. So switching over to the home-based care side of things. So it's widely understood in Canada and internationally that the volume of informal family care activity is immense, and that such care often reduces opportunities for education, employment, social connection, and well-being on the part of the caregiver. Of course, it can be difficult to quantify this care, but there's a report that was published by a group out of the University of Alberta looking at the economic value of caregiving that provides some estimates. So their work was based on a survey from Statistics Canada in 2018, and they found that there were 6.8 million caregivers in Canada who provide care to individuals with long-term health conditions, disabilities, or aging-related difficulties. And they found that these caregivers provided a total of 5.7 billion hours of unpaid care per year. And what they did is they used a replacement cost valuation method to generate an estimate for the value of this care on an annual basis. And at the low end of sort of their estimation range was a $97 billion value for the 5.7 billion hours of unpaid care on an annual basis. So of course it's quite staggering to be able to put a number to the family care and the volume of it, and sort of begin to understand how big of a role family caregiving does have in the larger care economy. And then just to touch on demographic trends in Canada that I think most are aware of, that are likely and already affecting the long-term care sector. So the life expectancy has grown and continues to grow in Canada, and this, along with the demographic wave of baby boomers entering later adulthood, is expected to lead to a scenario you can see in that figure on the right there, where in 2040, 2050, just under a quarter of the Canadian population is projected to be over the age of 65. So this projection will, of course, impose quite a substantial stress on the existing financial, organizational, and actual physical structures of the long-term care system. So there's sort of this need to examine the current state of the long-term care sector in Canada and potentially discuss alternative solutions to the traditional institutional long-term care. So with that, I'll pass it over to Smita for now to discuss the research gap we're hoping to address and talk through the scoping review that she led on this project.
So regarding the research gap, there is a significant gap in understanding how funds are allocated and spent within LTC facilities, which actually hampers our ability to assess efficiency and effectiveness in patient care delivery. So reports like Billions More Reason to Care, by the Seniors Advocate of BC, highlights concern regarding financial accountability in LTC facilities, emphasizing the need for improved monitoring and reporting mechanisms. And another study named Long-Term Care Financing, What's Fair and Sustainable, underscores the importance of transparency in financing reforms to ensure equity and adequacy in care provision. So despite the substantial public and private expenditure in the LTC sector, there is a notable absence of a comprehensive cost accounting system. So this lack of transparency makes it challenging to determine the actual cost of care per patient on a daily, monthly, or yearly basis. For patients and their families, understanding how resources are allocated within facilities is paramount. Transparent cost accounting empowers patients by providing clarity on how funds are utilized to support their care, which actually fosters trust between the care providers and recipients. So to address this research gap, we have two objectives. Our first objective is to develop a comprehensive and transparent cost accounting framework for institutional and home-based LTC settings in BC. And our second objective is, using the framework structure, compare cost between institutional and home-based LTC settings. For this, we had two approaches. Our first approach is scoping review to identify key cost categories reported for long-term care to inform the development of a cost accounting framework. And our second approach is, using this framework, report a breakdown of home care cost from a caregiver perspective, which Jenny will present in the next session. So in our scoping review, we had two questions. Our first question was, how are costs accounted for in long-term care settings? And our second question was, how do cost and benefit compare between institutional and home-based LTC settings? So here is our PICO for the population. The population of characteristics is frail and elderly requiring full-time home care or LTC facilities. Intervention is patients receiving home-based LTC, comparator patients receiving care at an institutional LTC, and outcomes healthcare cost, direct and indirect, and accounting or costing categories. So this scoping review systematically searched Medline, MBAS, CINAHL databases, identifying 3,700 records. After removing duplicates, screening titles and abstracts, 198 articles underwent full text assessment. Ultimately, 37 studies met inclusion criteria and were synthesized for analysis. So little bit about the characteristics of our studies. The literature we have selected were published between 2014 to 2024. So out of 37 papers, 14 focus on institutional LTC, while the rest are related to home-based care. The age of our population was more than 55 years, and they had disease like cancer, dementia, heart failure, COPD, and Alzheimer's. And the location of our studies are Canada, US, UK, Australia, Sweden, Ireland, and other countries. So regarding the cost categories, we extracted costing categories from these selected studies to develop our cost accounting framework. However, there is a high degree of variability in how costs were reported and accounted across studies. So we pick here some our costing categories and the number of papers you can see in the right side. So in the costing categories, physician visits, we have found these categories in 15 papers, and prescription drug we have found in 14 papers, personal care and home help in 10 papers, and informal care we got it in 9 papers. Regarding results, costing results, so we attempted to estimate cost from the literature but found a very large range of cost. So you can see in the table, like for physician services, the minimum value we got from our studies is like around $100, and the maximum is 6,000. And for nursing services, minimum is around 200 and maximum is 32,000. And for pharmaceuticals, it's minimum is 62 and maximum is 3,000. So we actually did not proceed with calculating and comparing cost from our selected studies. It's actually very hard to compare across settings and categories. And one thing I want to mention that we did not find any particular Canadian studies that aligned with our specific objectives. So from these categories, what we have found from our selected literature, we have developed a framework which Nora will present later on. So at this point, we actually picked two studies, highlighted two studies from our 37 articles. So this study actually about the informal care cost, the author is Higginson. So here the researcher explored the hidden cost and emotional impacts of informal caregiving during the last 3 months of life in England, Ireland, and US. They explored that family and friends provided extensive care, average around 100 hours per week. The activities included here like being on call, personal care, medical assistance, emotional support. And the cost of this unpaid care was actually striking. On average, 51,000 per patient, which actually consists of 58% of total care cost, and making it even larger than the formal care cost. So our next study is from Sweden. It's the study is about the societal cost of informal care, where elderly people are living at the community. So this study surveyed informal caregivers of frail elderly individuals who the age is more than 75 years and they are living at home. So the caregivers provided on average 245 hours of care over 3 months, mainly for household tasks like cooking, cleaning, shopping, transportation. So the average cost of informal care for this care estimated around 2,700 per person over 3 months, which actually annually near about 11,000. So the study underscores the significant economic and social contribution of informal caregivers. And right now, Nora will present our cost accounting framework, what we have developed from our cost categories.
Thank you. Yeah, so coming back to our objectives, so with the first objective being to establish a framework that we can use to account for the costs, and that can be used for both institutional as well as home-based long-term care settings. So as Smita said, since there wasn't an existing framework that sort of stood out and prevailed across the literature, what we've done is we've taken the data that we were able to extract from the scoping review and use that information, as well as through consultation with Jenny, who of course has firsthand experience with the costs associated with caring from someone from the home care setting, and we've used all that to develop this cost accounting framework. So the framework is structured into 5 main categories, with each one encompassing specific costing items. So the first category being medical care. So this includes items such as physician services, nursing services, and other allied health services, so things like physiotherapy, OT, and mental health counseling services. The second category is personal care, so this refers to costs associated with support for eating, support for washing and hygiene related activities, mobility assistant, and then any support and programming for outings or leisure activities. The third category is medical equipment and medication, so this refers to medications, and then other disposable medical equipment, and then the non-disposable medical devices such as beds, walkers, wheelchairs, etc. The fourth category is housing infrastructure, so this refers to any costs related to property maintenance and operation, any capital expenses, so for example if a renovation was required either in a home-based or an institutional setting, any housekeeping and laundry related costs, food costs, and administration costs. And then the final category is societal costs. So these are costs that are not typically accounted for from the healthcare perspective, but capture broader economic impacts. So this includes items such as loss of productivity, loss of leisure time, unpaid caregiver time, and transportation. And then, so our second objective was to actually report the long-term care costs in BC according to this framework that we had developed, and then be able to compare between institutional and home-based settings. Unfortunately, at this stage, on the institutional side, and Jenny will present on the home-based side, but on the institutional side, we weren't able to fully complete this objective because there weren't any studies identified in the scoping review that were able to provide that breakdown that we were looking for. The closest thing we have right now is an estimate that comes from the Office of the Seniors Advocates of BC, and this estimate is an average per diem rate for long-term care facilities in BC in 22-23. This per diem rate is $255, which equates to about $7,700 a month. And this rate reflects the base funding that's provided per bed to contracted facilities. In the report, they state that this aggregate rate includes items such as staffing costs, food and supply cost, administration, repair and maintenance, housekeeping and landscaping services, property costs, and capital. So it does cover, like, there's a ton of overlap between what we've done with our framework and what is included in this. It is just an aggregate measure, so unfortunately at the time we're not able to sort of parse out what each of those exact cost components are. So to wrap up with some conclusions, so we found that the reporting of costs across long-term care settings was inconsistent in the literature, and there wasn't a clear cost accounting structure that emerged. We also found that literature from Canada and similar jurisdictions wasn't available to provide a detailed cost breakdown for either the institutional or for the home-based long-term care settings. And with this information, we proposed a standardized framework that we feel can help to address transparency and accountability gaps in long-term care cost reporting. And we feel that future research should be done to validate and refine the framework across long-term care settings, both institutional and home-based. Thank you very much, and we'll open it up for questions.
Thank you, Nora and Smita, fantastic. And I think what you have highlighted even on that conclusion slide really lends to an opportunity, both with this grant as well as for future research to start to work within what we're putting out there with this costing framework to look at a breakdown of costs of long-term care and home-based care, and be able to put novel additions into the literature and into a policy space where people can grapple with this more openly, I think, and certainly what we're going to hear in a few minutes from Jenny is leading the way on that for caring for one's loved ones on a home basis. Before we get to Jenny, though, just wanted to take a few minutes now to entertain any questions, comments, thoughts. So looking around the room, if there's anyone who wants to jump in. I note there's a couple of comments online, which I will pose first to Smita and Nora. So the first one, just a clarification. Are these costs for informal care based on MD, RN, HCA, home care assistance, perhaps combined? So are the costs for informal care, healthcare aid? Thank you, Amanda. Are these costs for informal care based on MD, RN, and healthcare aid combined?
Was it for, which slide was that?
It was around the
value of time.
The like,
the literature review, around the informal cost of care.
like that I presented in the background.
No, the one that Smita was presenting. So we go back.
Guardian cost?
Here, that's cost.
This,
I think.
This one? I was not sure about like if this cost actually what they calculated. This is so this is about they calculated the personal care, medical assistance, and emotional. It's totally in the house. I'm not actually sure they calculated this point or not. So. So they actually calculated the only the personal care, medical assistance, and emotional support.
Okay, thanks, Smita. There's a second question about whether there's any data comparing the amount of care administered by family and friends to those in long-term care.
There was actually a report, I think not from this exact group from the University of Alberta, but a different group that looked at long-term care that family members were actually providing in institutional settings, so not just in the home-based settings, but the fact that family caregivers actually are providing quite a substantial amount of care in institutional settings. So I think the number was about like 40 hours a month, so going in and helping with various activities within the institutional setting. And they did also point out that this had been affected, of course, by COVID and the restrictions that were put in place around visitation.
Great, thanks, Nora. Further question online, what are the differences between in-home long-term care and home care services?
I think in-home long-term care refers to, like, broadly the fact that someone is receiving care that they would otherwise like receive in an institution, for example, and they're receiving that in their home. Home care services are services that might be a part of someone's home-based long-term care, so they might have clinicians coming from the health authority or whoever that's going to support their home-based long-term care, but there's also other stuff going on like family caregiver and informal care that's forming the whole experience of home-based long-term care. Does that make sense?
It does, yeah.
Yeah.
That's great. Excellent. Any other questions in the room or online before we transition to the next presentation?
Just one, the
Yeah.
slide before about the study in Sweden that had 245, was that including informal caregivers?
Yes, this is
Oh, okay, informal. Okay.
yeah, it's informal caregiving. Yes.
I just had a question. What was the rate they were using to come up with a dollar figure for the time that in these, like what
I think
rate per
it
hour?
varies, for this study specifically,
For
or?
the numbers that have been reported here, I'm just curious how that was quantified into dollars from time.
I mean, I think that it would vary a lot across studies. I know that, like that Canadian one I spoke of at the beginning of the presentation for like the valuing informal care, so they use like rates for like what it would cost to replace someone doing that task. So a rate for a personal care worker or a rate for a nurse. So it depends, and it would depend, I suspect, largely on where the study's being conducted, how they pay healthcare and care-related
Okay.
professionals in those settings. But
Yeah.
do you know any more?
Yeah,
Smita?
like sometimes they actually also calculated the opportunity cost, the loss of productivity for that particular work they will do, and they actually converted that value in the hourly amount, and that how they calculated
okay.
actually.
And in this study, did they say how much formal caregiving came from outside, or is it assumed that there's no formal caregiving, it's just informal?
So this study actually only focused about the informal care. They did not focus the formal caregiving. Yeah.
Because I mean, I'm just thinking out loud here. The care in the home, there's some help, maybe something from the health authority or from a private provider that comes into the home, purchased by the family, and then there's a family informal support. It's the accumulation of both that we're trying to say compare what comes into the home compared to what's happening in the care facility.
Yes.
I think that's kind of where we're going.
Yep, definitely.
Okay.
One further question online to Nora and Smita. Are there any differences in funding between in-home long-term care and home care services? I don't know, respond to if you want to.
My understanding
if you
is-
have any thoughts on that, or.
Well, I think for home-based services, there is a user contribution. So the health authority subsidizes, so there is a subsidized home support that comes in, but there is a income testing that happens, and the client contributes, and then the health authority contributes the rest. So that is those are the hours that go into the home. So there's that piece of it. And then, of course, if there's more that's purchased individually by that household, that would be private, and that would be their additional cost.
Anything to add, Nora? Smita?
Yeah, I mean, I think it's similar to the question before of like the actual home care services versus there's definitely going to be other costs that aren't covered by like just the cost of the service, all the sort of costs that we discussed around personal care, other equipment related costs. These are all going to be costs that are likely involved in caring for someone in one's home that you might not see getting compensated.
That's great. And I think we'll hear more about that from Jenny too. Anything else for now? All right, Nora and Smita, thank you. Excellent job. Fantastic. And now we're going to transition to Jenny's presentation. Thank you, Nora, for calling that up. Jenny, the floor is yours.
Hallelujah. So happy to be here. So grateful that you're here to share this work. Just to say that in my neighborhood, I have a neighbor, and he works in the field of health science, health research. And I would go out for walks with him. When I was walking the dog, I'd leave Mom in a situation where I knew she was okay for 20 minutes, and I'd get the dog leashed up and head out. And I'd say, Larry, I'm going for a walk, and he'd join me. And then I would just rant about how was this possible. And he led me to the SPOR Evidence Alliance and their request for questions. And it just happens that I have a PhD, and I am a certified project manager. And so I brought everything I had to bear to make sense of this experience. And first of all, to see, what am I missing? Is there something that I should be doing that could make this bearable? And then learn more about the situation itself. So here we go. I also have a Bachelor of Fine Arts, so you're going to notice that the cultural aspect of keeping this life rich and full is very important to maintaining one's health. So anyway, my mom was aging out of her place in a mental health group home. She'd been in it for 40 years. She'd moved in 1982, and it was the first time that she was willing to take medication, and then she became stable, and then that was where she lived. And COVID hit, and her health also started to need more. She had some health emergencies, and the family started to mobilize to help with her caregiving in the group home. And then we gradually made ourselves ready to figure out what to do next with Mom. Was she going to go into a long-term care facility, or would we bring her home and try and take care of her ourselves? As a frail elder with complex needs, she was extremely vulnerable to whatever caregiving situation she would be in, and we needed to have confidence that the care that she would be receiving by people who were paid to look after her would be something that we could feel confident and live with. And with the COVID factor, we just decided, well, how hard can it be? So we brought her home. She moved back home November 1st, 2021. It was her 91st birthday. Slides. So she immediately was diagnosed with pneumonia. She had COPD, and we went into health emergency crisis right away. And but this is meeting notes from January 29th of 2022, so we're 3 months into our caregiving experience. And my siblings have converged at my house, and my sister put together an agenda, and we met and discussed how are we going to do this. And so I had assumed the role of primary caregiver, although I didn't actually know that's what I was called. I just took on the job to do what I was doing. And I was already, at that point, I was working over 600 hours a month to look after Mom. And we had been put onto the palliative care registry, and because it was a 6-month registration and we'd never done anything like this before, we thought, oh, well, maybe she's only going to live for 6 months. So you're in crisis mode at that point, and you're just saying, well, we can do this for 6 months. These are the last months we have with our Mom. So we started to budget, and we set up a burn chart for managing our finances, and we created a shared calendar to manage Mom's schedule for the caregiving, but also for the medical event tracking. Because I didn't have any oversight of my job as that primary caregiver, I was always afraid someone was going to swoop in and say, you're doing this wrong, and you've neglected your poor mother, and we're going to take her away from you. It's a very odd fear to have, but it is there. So anyway, I kept meticulous records. With discussions with Larry and going through this experience firsthand and working with my family, I started to attend caregiving webinars, and the Center for Caregiving Excellence was starting up, and they sponsored a 5-session series discussing all these factors, and I was on LinkedIn and so on. So I used my graduate training to looking for research on family caregiving to help me understand the situation we were in and see if there was something I was missing. And then I wondered if my experience was unique, or was it something that was common. I couldn't find any cost accounting research, and of course cost was everything, because every day, every month, our resources were declining, and mom's needs were increasing, and so this measuring for cost is very important. Also, because you haven't done it in your life usually, you don't do a very itemized list of everything it costs. I really didn't know where everything was going. I just knew that we were depleting over time, and I was also burning out. Now, when I went to these online groups and so on and started talking about, well, where's the research, where's the costing and accounting research, the pushback that I got was that every family situation is different, every institution is different, and every care recipient has different needs. And I said, but I read the same study, like 97.1 billion per year. Okay, but what do we have in common? What's in common across every caregiving situation? And so for me, it was the bed. It started that we had a bed in our home. And the bed was everything that went on to support that bed was the work that we were doing. That work then so everyone has in common with this work that there is a bed, there's a care recipient who's in the bed, and there's 24 hours in a day. And that is a finite set amount of time that everybody has to manage and in the service of that person that's in that bed. So this presentation, I'm sharing the information I collected from operating my own home-based caregiving bed. And I started to think about it in terms of operations too, because as a project manager, I think of managing projects. Well, now I was setting up management systems for an operation. Mom did not die within 6 months. She quit smoking, we put her on the patch, and we got her off cigarettes. She was so happy to be at home and have her children dropping in and have the dogs and have the babies and everybody coming, and she'd say hello to the neighbors all the time. She was not going anywhere. So the nature of care, this is a very singular case study of one, and the nature of care evolved over 33 months from palliative care, where we were first put on the registry, through long-term care, which we were only actually on for about 4 months. And then eventually, right at the very end, we were basically operating a hospice bed because Mom was not deemed ready to go into hospice. So here we go. I'm telling the story. This is me telling you what I just said. I'm telling the story. I'm going to give you an overview of the work. I'm going to give you an idea of the methodology that I used to collect the numbers that I'm going to be presenting. I'm going to share the findings, a summary of the findings, and then my conclusions. So part of this work, it was a transformative experience for me, and one of the results was I wrote a song about it. This is from a song I wrote called The Caregiver Shanty, and this was a song for landlocked caregivers, especially those who had family members with sailboats that were sending back vacation pictures from their sailing trips in the summer while you were cleaning out the commode and making sure Mom had another cup of tea and a bun with butter. So, may I share this chorus with you? May I sing?
Go for it.
Okay. Well, this is the chorus. Sing, you caregivers, sing. We've got rich stories to tell. Sing, you caregivers, sing. Sing out loud in the morning. And this is all about the work that we do day in and day out. So There's an absence of so 1 in 4 Canadians are giving care to family. This is the same, from the same Stats Canada report that was reported earlier. But there's an absence of cost accounting data. The cost to operate a caregiving bed in a family home, the comparative costs of operating a caregiving bed in an institution, and then a no barrier cost rationalized support for home caregiving. There's a rationalized support for institutional beds. We need a rationalized support for home-based beds as well. And so we want to change, the problem that we're addressing is we want to change that familiar refrain. It costs less to take care of our seniors at home. And we want to add, but it does cost. How much? So the objective of this report is to support initiation of a cost accounting approach to research, legislation, and operations management. I don't want to hear that everything is different and it's too complex and complicated. It's not. There's a bed and we can figure out what it costs to support that bed. So we want to ensure that there's equitable supports are provided to all caregiving beds, whether they're located in institutional or home-based settings. So the goal of this work is to ensure families who operate caregiving beds in their homes do not experience increased risk of social and economic vulnerability as a result of their family caregiving time. That it's been shown that family caregiving households have higher and their risk of socioeconomic vulnerability increases over time, even as the needs of their care recipient are also increasing over time. So it's truly an unsustainable situation. So with family caregiving, the framework is great. There's one piece of it that I think we have to take into account, which is the way that when you're running your own caregiving bed and you are the primary caregiver and you're getting all the help you can possibly find that you have time to try to find. There's this feature of time confetti. So when you're doing, you're supporting your person to get to the toilet or to get their breakfast or to get their pills or to organize a drugstore run or to organize a doctor's appointment. All of that stuff is just happening throughout the day. So it's much harder. It kind of all falls under that personal care costing, like it doesn't break out quite so neatly into, say, the housing category. So the setting overview is that we were in our home in East Vancouver. Mom had the basement suite, and she had her own bedroom. There was a bathroom. There was a bedroom for the caregiver because she had to have somebody with her 24/7. And then there was a common area where it had the kitchen, the dining, and the living room all where Mom sat. And then in the back corner there, I set up an office for managing the work and taking care of all that. And there was a small little entry area, and we could put her out there in her chair, and she would sit out there in all weather actually, and she just loved waving at the neighbors as they walked past, and they loved her. There was much sadness in the neighborhood after Mom was gone. So the timeline for this schedule is that we started getting ready. We actually renovated the bathroom in that basement suite in Christmas 2020. And that cost is not added in this report, but it was $5,500 to remove a bathtub and put in a no barrier shower base. And so then Mom moved home. So the first 2 months there, I wasn't tracking. I didn't have the schedule up or anything. I was really just basically running a steeplechase. And then as of January 1st, 2022, I started collecting everything I could. And so we've got year 1, year 2, full year, and then year 3, it's 9 months. I took it right to October 4th. That's the day Mom passed. So we have a frail elder with complex needs. She was born in 1930. She had 6 children, and was diagnosed with paranoid schizophrenia in 1966, and then went into mental health group housing in 1982 and came home in 2021. And so her health needs, she had the mental illness, dementia, COPD, rheumatoid arthritis, suspected and undiagnosed cancer, that because if it wasn't reversible, she couldn't go get treatments to even do a thorough diagnosis. And then age-related issues like incontinence, swallowing, dentures, digestive issues, and weakness. So these were the things that Mom was living with and that we helped her with. And this is a picture from Mom Moves Home, her life in boxes. And it's just we love that there's a box labeled nice outfits. So, accounting of materials and time. This presentation reports the family caregiving work carried out on behalf of my mother. I was the primary caregiver. So with material costs, I had power of attorney over Mom's affairs, including her bank account. So the main financial data in this report is from our bank accounts and my credit card accounts, all under my authority. My family did provide some financial data, help with fill in some of the blanks, and I was able to download that financial data for coding. And then for time, I was administrator of the scheduling for Mom's care. So that included the family caregiving commitments, the medication schedules, specific illness care like ear infections, and prescription results for reporting to the doctor or the palliative care nurse, and also the meeting and greeting and departing of the home support visits, which happened basically 6 days a week. So I was able to refer back to these records to calculate the caregiving hours. So we went with the cost accounting framework coming out of the scoping review, which worked at this level of these 5 basic categories. I was able to use it. So I accounted for materials and time. That's how I broke out the cost accounting. The medical care is pretty much all covered by MSP. In our case, we also had a physiotherapist coming to help Mom get her strength back after some catastrophic health stuff earlier in 2021, before she came home. But the cost of that was, for 2 visits a week, was $1,000 a month. And so we had to stop after we realized how much we were paying for it, and we just was like, we'll do it ourselves. So we got the physiotherapist to train us and took on that work as well. So then in terms of time, here's a year at a glance for 2023 to give you an idea of how we were, by 2023, now we've gone through our re-up on the palliative care registry was happening. We're now in our 3rd time renewing our 6-month registration. So we're still on the palliative care health registry, we're not in the long-term care world. And what I understood was that our visits from the home support for respite, we could have 2 hours a week. And as I was doing the work, I realized that 2 hours was not a respite enough for me to recover, but I had to vacate the premises in order for the home support worker to be there with Mom. And by then, after the first year, 2022, my work was winding down and I was not trying to find any new consulting clients. And I was starting to understand the amount of work it is of bringing people in, preparing Mom, bringing people in, having them do what they do. Then they leave, and then I bring Mom around again. So there was quite a bit of work entailed on me as the primary caregiver for every person that came in the door. And so that 2 hours a week, if you look at that time, it's less than 1% of the caregiving time that's needed. So after 2022, 2023, I just thought, we'll just do it ourselves. Can we do this ourselves? And we had, so the breakdown here, Mom has 6 kids. They have partners by marriage. And also my son would come from Victoria for 3-day shifts. And he was paid a fee that actually went down over time per hour, even as his hours increased, because he was one person that Mom knew. It was very easy, and then I could go upstairs to my second bedroom and get some rest and not be responsible for listening. So in 2023, at the bottom you can see there's 8,761 hours. That's 24/7. And then the percent of total hours worked. Well, I worked that year, I worked 6,127 hours. And I covered 70% of Mom's caregiving time. And this was working very diligently with my immediate family to have them make commitments for time and to come and help. But we're also asking them to put their unpaid time in as well. So then that just depends on what they can afford to give. And for us, I calculated the rate as a risk mitigation rate, not a replacement cost. So I just said, well, if we made it $5 an hour, a 24-hour day is $120. Well, that's half, that's less than half the cost of hiring a market rate service to come in, and I don't know what the rate is. That we can't even get a home support person to come in and do that kind of replacement. So that's how I factored a price for time in this study. And so then in 2023, the cost of time to the family was $39,448 based on those numbers. To myself, it was about $30,600 that I put in for Mom's care. So this is what that looks like in terms of the time that's being provided in our household to operate this caregiving bed. Those orange lines are family, and the blue is my son coming in, and the green is the emergency long-term care that came in right at the end in the last month. And that orange color in the first year is the paid. We paid an external service from February through November to come in twice a day for 5 hours a week, so 10 hours a week. But they were $39 an hour. And so if I wasn't making more than that, the cost of me being away was the value wasn't there. So that's how that worked. So we went with the questions that were, how do we make it so we can support a household to operate a caregiving bed? What is the bare minimum that a household needs to make this work sustainable? And it's a given that we cannot pay a family caregiver what they're worth, but what is the cost to the household that would sustain household economics to operate this bed? And so as I worked on this presentation, I had 3 inputs on how to factor the cost, just those hours of care that we did. One was the idea around replacement cost. Would it be minimum wage? What's the institutional rate for a care recipient? We didn't know what that was. A contract service, just say $35 an hour, and what labor laws would apply for a 24/7 caregiving schedule. And there were many instances where I worked at least a 24-hour, sometimes 2 days back-to-back 24 hours, and in rare circumstances I actually had 3 days back-to-back of 24-hour days. So for the purpose of this report, we used the risk mitigation cost, or I thought I invented it, but I guess I didn't. What would it cost to compensate family caregiver time to reduce or eliminate the cost of time lost? So what that productive time and the leisure time loss, what would the cost be? And that's where I came up with the $5 an hour rate. My thinking was, for heaven's sake, if we had been compensated for our costs that we incurred, we would have just been so relaxed and happy to look after Mom. It was the stress of declining resources over time and the feeling of being taken advantage of, the feeling of being taken for granted for this value of work that we were putting into the health system, and we did not feel that there was a reciprocal value being returned. So that idea of societal cost, the time is a zero-sum equation. That the unpaid caregiving time, there is no magic time that makes that up. You have lost productive time, or you have lost leisure time. When I was looking after Mom, I didn't have to sit and stare at her 24 hours a day. I took care of her, and I went off and did something, and then I came back and took care of her again, and I went off and did something. And that cycle of care was about 20 to 30 minute times. Rarely, I might leave her for an hour if she was sleeping soundly and I knew she wasn't going to try to get out of the bed or do something that I'd go, what happened now? So there is no magic time genie that gives unpaid family caregivers time. They are spending time. So then with the sample coding for the framework, I broke them out with the health provider, palliative care, long-term care, MSP, the home support, and then also material costs, and that was just basically that physiotherapist at the beginning. And for the personal care, I calculated up all the material costs, so anything that we spent directly on Mom came under personal, so hair and nails or clothes and things like that. The medical equipment and consumables, that was material as well. And I put actually pharmacy in there. And then the housing infrastructure, that was all material costs. And the societal costs were basically all time costs. So the time that we got from MSP home support, that got rolled back up under medical care in terms of time. The funds that we expended on paid caregiving, those came in under as a material cost to personal care because there was a receipt. We paid for it. So then I apportioned those amounts. So for the MSP, basically covered by MSP. The personal care was 100% cost to Mom. The medical equipment and consumables was 100% cost to Mom's care. The housing infrastructure, I broke it down by square footage. So the suite was, I thought if I was operating a long-term care bed as a home-based business and I was reporting to CRA, what would I be allowed to report as an expense? So that's how I calculated that. So property tax, the mortgage, the insurance, Fortis Gas, and the water and sewer, they came out at 37. Hydro, the suite has its own account, so it was 100%. And the rest I just assigned to Mom at 10%. It was essential infrastructure, and I usually when I used it on her behalf. But the entertainment I did 37% because she did listen to music on the streaming. We watched TV on the channels that we got through our streaming, and so that seemed like a fair. And then the societal costs, the unpaid caregiving time. This is the team of 11 that put time in. And over those 33 months, I averaged 525 hours a month. So then with our findings, I tallied up the expenditures, I tallied up the hours. The expenditures was a percent to caregiving, and that was the material cost. The hours were 100% to Mom, and that gave us our hours count, and then there was a second calculation to take the hours count by a rate per hour to give us a time cost. And then we have the material and the time cost divided by the number of months, and that gives us a total cost per month. So the way that works out on the per year, and the thing I was surprised with doing this was that I had not thought about the material cost as being as impactful as it was. But it's a suite it's a 2-bedroom suite in Vancouver, so that's what it is. So anyway, 2022, the material costs per month were $4,500. The time cost, the unpaid time cost was $32, and the total per month cost was $77. And that included us hiring that external caregiving service, which was worth about $16,000 that year. And we purchased a wheelchair that year as well, and that was about, $5,000 all told. $500 for the cushion. Then 2023, the materials were $2,600, the time $32.87, and the total per month was $58.92. And at this time, we'd stopped paying that external caregiving service, and this is when Noel's rate went. The time went up, and the time paid went down. But he kept coming, so we're grateful for him. Then the final year, it was 9 months, and so our per month costs were, and in this one, then we actually had the cremation cost. I added it in it was $4,700, so I added it. So the materials were $3,700, the time $31, and the total is about $7,600. So over 33 months, the monthly and per diem average for all of those, for those costs, it works out to about $6,900 a month for materials and time, and the per diem over 1,008 days is about $224.97. So in fact, it is cheaper to have people at home.
Like $25 a day.
So, over 33 months, the institutional cost for that would have been $7,000 at $255 a day. We have no idea what that means, that amount. Like how many times mom's being interacted with, how rich is her life? Would they get her to quit smoking if she didn't want to? That kind of thing. So anyway, $76.50, and we delivered for $6,800. So this limits study does support the assertion that it's cheaper to have someone at home in spite of all the advantages inherent in an institution. The institution has an economy of scale. A single worker can care for multiple care recipients. A single building can house multiple care recipients. That there's shift work in the institution. A worker's working according to labor legislation. Institutional workers are protected from burning out, at least to that degree. And that there's a professional administration team. They're paid to plan, supervise, and manage the care work in the institution. And despite these advantages, our family was able to bring mom home and take care of her for less than it would cost in an institution to take care of her for a much higher quality of life. She came home with a life expectancy of 6 months and stayed with us for 3 years. However, this study shows that it does cost the family something to do this work. So the summary notes, hang on, that's my call to action. Wait a second. Okay, wait, I got these mixed up. We're good. The call to action is that we need to measure, account for, and provide funds to households operating caregiving beds. We need to establish home-based caregiving as a priority healthcare research topic because there are millions of households doing this, and there's going to be more, and the long-term care infrastructure is stressed. We need policy and legislation to budget for costs. We need institutional support for caregiving households, and it should be supported by the healthcare system. Family caregiving households are not an entrepreneurial enterprise. They are a no-profit mission. And it's a no-barrier guaranteed income supplement. Call to action, a no-barrier guaranteed income supplement for caregiving households. However, those benefits might be sorted out in terms of, say, property tax or other ways that the material costs of households can be helped. And then identify and register family caregiving households so they can receive a guaranteed income supplement. Many people who are doing family caregiving and even are the primary caregiver do not identify themselves as having that role. They just see themselves as doing a noble service to their family to help take care of a family member who can't fend for themselves. And over time, that feeling of nobility turns into stress and resentment because they end up alone and isolated with this incredibly valuable, but incredibly difficult work. So, summary notes, we did a single case family caregiving setting operating a palliative care bed for a fragile elder with complex needs. We covered 33 months of data collection in this report and in our caregiving experience. We did perform a proof of concept to apply a cost accounting framework to home-based caregiving setting, identified the cost categories to test across diverse settings, institutional and home. And my conclusion is that we could definitely use this framework, that just those really basic categories could form the basis for the next step of research that could say select for 10 beds in 2 settings and have our data collection models sorted out across those settings, because even doing that work is going to give us something that'll start to be able to be generalized. And so I say thank you for your attention. It is most gratefully appreciated.
Thank you, Jenny.
This is my sister. On that hours list, she was the family member had the next highest number of hours. She was making trips in from Maple Ridge every week to come and spend an overnight with Mom, and she'd stop at the grocery store and she'd come and make delicious food for us, and I would go upstairs and lay down and she would come and spend time with Mom, and made all the difference in the world. So, any questions?
Yeah, thanks, Jenny. Brilliant. I'm sure there will be lots, and I think, the emotion in the room clearly is appreciating you and all you have done, and I would say just from the research side, you're meticulous accounting, which lends to your personality and your project management and your many skill sets, but also your passion for what you did for your mom, and then wanting to report out. So so appreciate all, Jenny. There is some stuff online coming in. One thing that just I want to clarify, did you include in your cost accounting the administration time you spent coordinating schedules?
No, that was all included in that lump of hours attributed to Jenny. I was doing that work while I was caring for Mom.
Right, so it was captured there.
It was captured.
And I mentioned that because I noted on one of your slides you had administration time for a long-term care facility, and so I wanted to just draw that you were capturing that as well.
I actually had a long list of the jobs, the roles and responsibilities that the primary caregiver I was taking on, and I used a standardized list from project management to articulate those roles, like administration, scheduling, just the whole gamut of them. Yeah, it's a high level of function that any family caregiver is running in order to run this operation.
Yeah, absolutely. And I'm actually amazed too, just reflecting on the findings. I'm amazed that the ballpark of the seniors advocate figure for caring in a long-term care facility, and your N of 1 cost accounting is so close.
It's
incredible. That's kind of rounding error, really, 225 to 250 a day, but I find that fascinating. Questions, thoughts, comments? Yes, please.
So I have a question about that exact thing, because you valued time at $5 an hour, and you come out with that number, which I also was going, wow, that is very similar, but you were valuing the family time at $5 an hour. How does that get?
We don't know, because we don't know what that $255 represents. We don't know we can take our number and break it all out into this is how it factors. But we don't know how that per diem rate factors right now. It's a baseline number but we don't have supporting data that shows, oh, this is how that's done. This is what goes to administration, or this is what pays for the utilities guys.
Because
or-
obviously the people working in a long-term care facility are making far more than $5 an hour.
Well, yeah, of course, yes, it's, and they have those economies of scale. So we don't know, is the point.
Great. Yeah.
Hi, Jenny, just to start, thank you for a wonderful presentation, and really, what you describe is more than just caregiving. There's a passion here, there's love for your mother. There's just so much more that's just not captured in that title of caregiving, and I commend you for everything that you did. And it was so wonderfully presented here, and to the family that was part of that caregiving journey. I thank you for singing the sea shanty. I think I calculated in my head it's been 30 years since I heard singing at an academic conference, and I hope it's not 30 years before the next time. I have two questions, and one's methodological and one's more about the caregiving journey. So the first is there any consideration to, for want of a better term, the usual cost of living as a deduction from your cost accounting? Because when you include things like housing, food, like those are things that I incur as someone who's fortunately not a recipient of much healthcare, and so as a way to sort of level set against the cost of what it means to provide care.
Yeah.
And certainly so question there. And then the second question, which is kind of unrelated, is in hindsight, what are the things that you wish you didn't spend money on or time because they didn't add value or they didn't help your mum, that we can learn from and not do those things, because we're sure good at doing lots and not necessarily good at saying, well, we shouldn't have done that. So thank you, Jenny.
Okay, thanks. First of all, to the cost of care and the cost of living. One thing I didn't add in was the cost of our household supporting that second bedroom. So Mom needed someone to look after her 24/7, so that meant that the household was also supporting that second bedroom, but also their food and their, but I didn't count for that. In terms of how we portioned out, say, that cost of living thing, for Mom, I basically made her groceries 10% of what we spent on groceries. And honestly, I didn't have all the grocery receipts for the 3 years. I did a calculation from what I could get to say, well, that seems like a reasonable amount that a family of 4 would spend on groceries. And then I gave Mom 10% of that. So that's how I sort of did that. The square footage was the housing infrastructure. And so in terms of cost of living, if Mom wasn't occupying that suite, we would be renting it, and so that would have been contributing back in. So that's why I added in the portion of the mortgage and the portion of the property tax and everything, because those, if I was running anything there, I would be expecting to make up that per square footage, that space would be paying for itself back into the household. So that's how I did that.
And not do things.
Oh yeah, well, so I'm gonna say that one of the most valuable things for us, even though it was taxing on a day-to-day basis, not because of the work that the people coming in and out, is being sensitive that anybody coming out of the space, the caregiver is orchestrating. And so there's work there to prepare their receipt. Is she awake? Is she in the middle of a meal? Is she oppositional right now? And if we wait a few minutes, she'll say, yes, I'll go in for the shower. That personal care and the showering service from home support was critical. I tried giving Mom a shower once, and you take 150-pound, slippery, fragile, mobility challenged elder once, and you go, okay, we're not doing this. So that was super valuable. The part that we didn't get the value from, but I didn't know, was what we spent on that external caregiving service. They came in, they did light housekeeping as part of their service, and I thought, okay, that'll be great, because they'll do some laundry and so on. But the fact was that those tasks individually take a few minutes, empty the dishwasher, load the laundry, fold the laundry, sweep. And then they spent time sitting at the table while mom's just sitting there, and they were writing these very meticulous notes of every single thing mom did, like when she peed and, you know, all of this stuff. And I never looked at those notes until in one of my previous versions, I had a screenshot of one page of those notes. So that was not worth it for us. And the physiotherapy, again, once we realized we could train ourselves and do it with mom, $1,000 a month for 2 visits a week for, you know, a half hour, 3/4, no, it's not worth it. One of the good things was because mom came from a mental health group housing situation, she took many medications every day, in the morning, in the middle of the day, and at the end of the day. And we simply transferred that service to our house. So they were delivered every week. They came in pre-marked pouches. And so all we had to do was follow the timings on the packages to give her what she needed. If we had just been having all these bottles of pills and inhalers and all of that, it would have been much more difficult to manage that as an unskilled, you know, medical dispensary, you know, nurse.
Shelley?
Yeah.
Thank you.
Yeah, thanks so much. I mean, like, this is why what we call patient-oriented, but, you know, caregiver-oriented research is the way that we want to do research moving forward, is that lived experience perspective being at the center of what we do. So I thank you for your passion, and I thank you for your engagement and your leadership on this work. You know, one of the things that strikes me is, like, you could have just given up at some point, and I'm sure that you were probably close at times to just giving up. In which case, then your mother would have needed to be transitioned into an institutional care. That cost would then have been incurred by the system. So there is like a sense in which, like, you know, we need to recognize that the system is actually not incurring cost as a result of your family taking on that responsibility. So, like, the fairness in that, like, it seems like important that we sort of try and work through how do we do that, because yeah, we could, like, you could sort of arrange for a strike of caregivers nationally and the system would collapse. So we need to sort of recognize that. The other thing that is on my mind, so I know Anna Dixon, UK-based, she chaired a commission on social care for England. And one of the things, like, it becomes like more of a sort of social conversation or a societal conversation that we need to have about, like, who has responsibility for providing. I mean, there's the medical care, which in a sense is dealt with, and you recognize that, but it's the social care side. Like, who has that responsibility? So I'm just looking at the report that she's done, and I'm happy to share it. But, like, one of the things that she came to as a conclusion after this big consultation was there's no clarity about what should reasonably be expected from families. And we need to have a conversation about that. And then she goes on to say that there's no clarity about how the costs of care are shared between individuals, families, and the state, or in our instance, the province. And I think that's something that we need to actually, like, have more of a conversation about as a society, recognizing that, like, you know, you chose to do that, and you know, yeah, you could have chosen differently, and there would have been very different sort of scenarios, both for your mother, but also for the system. So I think like that's sort of more general, like, conversation that as a society we need to have about who takes this responsibility and who supports those people who take the responsibility is probably where we need to go.
I agree 100% that for us as a family, for me as the daughter of my mom, the stress of putting her into a situation where I might not be able to be there to know what was going on and to know that she was being properly cared for and that she was comfortable and happy, that's also a social cost. And we, in the beginning, when we take on this responsibility, like, my mindset was absolutely, it's our family's cost. we raised children. We didn't expect to be, to have the bed that our child grew up in paid for. And so I didn't think of it differently. It was only as I understood the enormity of the responsibility, the amount of work and the level of authority that I was assuming with no training. So now I've got hydromorphone in the house. The palliative care nurse has said, you're gonna have a narcotic in the house. And I'm like, well, I'm just keeping all the medicine here on this little shelf where it's easy to grab. What does it mean if I have a narcotic in the house under my authority, under my administration? And so I 100% agree that, and that's why I think it's a risk mitigation approach as opposed to, oh, now we're gonna professionalize care in a family setting. Because when Mom had people paid to come in and look after her, they sat. In one case, Mom's in her bed and the person is sitting in a chair in Mom's bedroom, just sitting, like watching her. And Mom was not comfortable, but she couldn't say, could you go sit out in the living room? I don't need you watching me sleep. And so I think that is exactly where we are, in that as a society, as cultures of family, and as economic systems, we take care of each other and we support each other to do that. We don't expect people to simply have to sell their house at the end of their care, after their person passes, because their line of credit has gone up over what they can. Now they're retired, all they've got is CPP, and they can't, so that's I think you're absolutely right, Sterling. That's a conversation that we have not had, and it costs something.
Jenny, there's a comment online from Tamara, who is the Provincial Director of Specialized Pediatrics in Health Complexity at BC Children's, and she makes a comment about how some of what you're presenting certainly resonates with families who are dealing with complex kids in their homes. And it's just a comment, actually, just to encourage. Thank you so much for sharing your experience as an individual and family who loved and cared for your mom. This is such a powerful presentation. Your ability to document your life is incredible through such an emotional journey. So, with thanks for that from Tamara in the system. And then Laurel writes, what might be involved in the monitoring of quality of care by families? It seems that your family was informed and committed to quality of life, of course. Some families might not have the same knowledge, resources, or commitment.
Exactly, and so yes, hello. Good question.
Yeah.
How do we manage for quality and risk in an institutional setting where a bed is being operated? What are we doing there? How can that be translated to a family caregiving bed? Now, here's one thing I'm thinking about all of this, is that let's just say that your elder is having difficulty fending for themselves. You're attending the doctor's appointment with them because you need to take notes and you want to make sure, and you're probably the one that's going to the pharmacy. And in that moment, the doctor says, I'd like to register you as a family caregiver. And in that moment that person is registered, has the option to register as a family caregiver, they become part of the healthcare system. And now whatever we're doing to manage for risk and quality in the home is of the same, at least, I mean maybe even better, I don't know, of what's going on at an institutional level. The anxiety of taking on this responsibility with no authority and no oversight and no one coming and saying, well, you might want to get that rug off the floor because it's a tripping hazard. It's nerve-wracking because I'm not a gerontologist. I I don't know I only know the risks after they've happened. So I think that is part of what it becomes when you say, this is part of our healthcare system. It's a critical element of it. As Sterling said, if the caregivers can't go on strike because their person would suffer, and part of what we do is we don't want our people to suffer, so we can't. But if we did, the contribution of caregiving beds, like I'd like that counted. Could we count that? How many caregiving beds are in operation right now in Canada?
Do we know that?
No, I don't think we do. We don't know much about it, but it would certainly be an interesting number to have.
Well, there was the number 6.8 million caregivers.
Yeah, that's time.
At home.
That's time. That report doesn't measure at all for material costs. It's only time.
But the caregivers are providing care to an individual. I mean, there's probably, there could be more than one caregiver for a particular individual.
They're also, but then in that one, they're also doing that other caregiving work of family caregivers coming into an institutional setting.
Mm.
And they're making sure that, you know, they're eating, or they've gotten changed, or they've had a bath, or all of the stuff that they do to support their person when they're in a long-term care facility. So it doesn't necessarily translate to households, but okay, let's just say 1/4 of Canadian households are carrying out some level of caregiving responsibility. Let's start there.
There's one other comment online just to say, amazing informative presentation. Thank you for sharing your experience and your contribution to society. I'm going to suggest we take a break, stretch our legs. We've had a lot of information and a lot of emotion, positive. And again, Jenny, thank you so much for sharing your experience and contributing to this journey and our project. We'll take 20 minutes for a break, so those online, feel free to come back at 11 a.m. Pacific. Those in the room, there's some refreshments, stretch, and then we do, for the rest of the morning, do have some planned group work where we want to kind of talk about next steps, where to take this, how we might put this forward. Obviously appreciate some people may drop off online, and those in the room may head off, but if you're able to stay for another hour after our break, we would greatly appreciate your contributions for the remainder of the morning. So we'll see you back at 11 a.m.
No, thanks.
I set it up. Nice. Provide so much important and interesting detail.
So, thank you for getting the,
Looks like there's
making the system.
side of our team, 6 people in the room, and about 25 online.
So for good?
Oh, you're on a lot, yes, you're
Good work. What? The worst feeling? No, you're good.